The knee. The next lectures that we're going to be looking at concerns the pathologies that may be found around the knee joint. At the end of the lecture, you should be able to be aware of the main injuries in the knee region and their mechanisms, be aware of the main clinical investigations in this region and how to interpret them, and understand the principles of conservative and surgical management of common knee injuries. First of all, I will very briefly skip over some of the clinical anatomy. If you want to review this in more detail, please refer to the slides that are relevant. The knee is one of the largest synovial joints in the body, but it is also one of the most commonly injured. Reasons for this include poor stability offered from the bony components, stability reliant on ligamentous restraints, and the weight-bearing joint is exposed to extremely high forces. So, in conclusion, the reason why the knee joint gets injured, relatively common, is that it doesn't have an awful lot of bony control or congruency, and the ligaments are relied upon a lot more heavily, and it is also exposed to some rather large forces. It can be exposed to large forces. The joint of the knee lies between two of the largest and longest levers in the body, the femur and the tibia, and hence the leverage at the joint is large. There are three articulations: the tib-fem joint, the patellofemoral joint, and also included in this area is the tib-fib joint. There is relatively a varus alignment of the tibiofemoral joint. The knee can also be considered as the three articular components may be considered as the medial and lateral compartment and the patellofemoral joint. We will also consider the superior tib-fib joint within the knee area as well. But you must consider when considering pain that is in and around the knee joint that it may be referred from either the lumbar spine or the hip and the superior tib-fib joint. What comprises the medial compartment? The medial compartment comprises the medial side of the knee, the MCL, the medial meniscus, the joint surfaces, and the extensor mechanism which controls around the medial compartment and the medial muscles of the thigh, such as the pes anserine tendon, semimembranosus, and divisions of those tendons. The structures are highly developed and provide dynamic stability. The medial compartment does, however, come under considerable forces during either compressional injuries or tensional injuries, much more frequently than the lateral compartment. The lateral compartment consists of the joint surface, the lateral meniscus, the lateral collateral and anterior cruciate ligaments, the lateral part of the extensor mechanism, biceps fem, ITB. It is less commonly injured than the medial compartment, but is more susceptible to degenerative type changes. We will be looking at these arthritic type changes later in the lecture. So let us now consider the pathologies of the knee joint. Disorders of the joint surfaces, as they may be called. These are the group of problems known as arthropathies or joint-related conditions. These include rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis. There are also various infective arthropathies such as pyogenic tuberculosis or syphilitic arthritis. There are generally degenerative arthropathies that may also be associated with this area, such as OA, osteoarthritis, or chondromalacia patella. There are some joint surface dysfunctions which have unknown causes or may be multifactorial in their presentation. Examples of this are osteochondritis dissecans, which occurs mostly at the patellofemoral joint. The pathology of the above conditions is the same as for any other joint seen around the body. The most commonest pathologies seen are the degenerative and traumatic arthropathies. We will now consider some of the more common arthropathies that are visible and seen by clinicians around the knee joint. The knee joint is one of the commonest sites for osteoarthritis. That is because of the weight-bearing component of the knee joint. It may occur in any of the three articulations, the medial lateral compartment or patellofemoral component, and in any combination, although usually it starts in the lateral compartment. It is seen generally in the older age group, from 50 or 60 years old, and may occur in younger individuals, perhaps post-traumatically after an accident. The site of degeneration may vary according to the contributing factors, such as the biomechanics of the area, the amount of support supplied by the area in terms of muscle strength and dynamic stability, the biomechanics of the foot and the position of the foot in loading. All of these factors may occur or may affect the site of degeneration. As said previously, the lateral compartment is more prone to degeneration due to the sustained loading, as you can see in the diagram to the right, where the compressional component of the joint is more lateral compared to the tensional component of the joint being more medial. Depending on which compartment is most affected, the various signs and symptoms of osteoarthritis may include pain and loss of function, most particularly with activity or weight bearing, crepitus, which is most noticeable on flexion in a loaded position, degenerative X-ray changes, swelling may be minimal and may be compartmental, so you may see it more on the medial or the lateral side of the knee. Deformity of the joints margins due to osteophytes, and these are seen in more advanced cases of OA. And the varus and valgus deformity if a single compartment is affected. So looking at the diagram to the right, the varus deformity is seen with medial OA knees, and valgus deformity is most likely with the lateral compartment. So how do we manage OA of the knee? It's similar to any other management of this joint arthropathy, OA. It will include rest and weight loss where indicated. So relative rest is important. They should not be told not to do anything, but to include a strengthening program which has relatively non-weight bearing exercises. They may be given support, and this may be both physical and emotional in order to help them. The physical side of things may be from crutches if necessary, or from tape, taping techniques, or it may be from more generic supports such as those seen with neoprene or sports management. The more emotional side of the support may come from family, friends and people helping them during a bad time with their OA. Pain management is usually indicated during, again, bad periods, and this may come from TENS machines, interferential, and also low-grade mobilisations are a very useful way of managing the joint arthropathy. Non-weight bearing exercises, as mentioned before, are very appropriate in OA of the knee, and these may include particularly exercises for strengthening the quadriceps in a low load position. Mobilisations of the knee joint, particularly the tib-fem joint or patellofemoral joint, can be done at the appropriate point in range and are normally performed as a higher form of higher grade mobilisations in order to manage pain rather than or affect range of movement, but your aims must be clear at the start of the mobilisation. You should always take into account the severity and the irritability of the condition. The strengthening of the anti-gravity muscles is important, and the use of non-weight bearing and partial weight bearing activities to increase strength and general fitness aerobically. So, for example, swimming is a good aerobic activity to give, and hydrotherapy may be useful. The management must relate to their function as well, and with this we need to consider how people with OA are managing the rest of their lives and give the support necessary, or put them in touch with a support network which helps them. On a medical front, non-steroidals and or painkillers may be prescribed, not by the physio or rehab involved, but by appropriate GP involvement. In severe cases where conservative treatment has failed, then surgery may be indicated. Let us now move on to a group of pathologies known as osteochondral injuries. And these are injuries of the cartilage and underlying bone of the knee joint. One of the most commonly seen osteochondral injuries is a condition called osteochondritis dissecans. It is a variety of the osteochondral injury where a single or multiple fragment of the cartilage and possibly the subchondral bone becomes separated from the underlying bone. It is most common on the convex surfaces of the femur and is commonly seen possibly after trauma or during heavy weight-bearing type sports. 85% occur on the lateral side of the medial femoral condyle. This is the most common site for osteochondritis dissecans to occur. What is the most common etiology of osteochondritis dissecans? It is generally unknown, but as mentioned before, trauma may well be a single contributing factor. It's usually seen in young athletes between about 5 to 20 years, and in adults it occurs more often in males than females. The fragment may remain attached, and if so, the pain is generally dull and achy, poorly localised around the knee joint, and worse after activity, particularly loaded. It may also occur at night, and there will generally be swelling of the joint. If the fragment has broken away and it's loose within the joint, then this may also present with intermittent locking or giving way, usually found in extension. How do we manage osteochondritis dissecans? If the fragment is still attached, then rest and avoidance of weight-bearing activities for between 4 to 6 weeks may help, and a graduated return to activity with proper management in terms of rehab is important to correct biomechanics and allow the healing of the chondral surface. If the fragment is loose, then and conservative management fails, then surgery may be required. Management is often aimed at reducing the swelling, restoring strength, and helping to manage the patient with fitness and mobility exercises post-op. Pain management may be indicated, as discussed before. Patients that present with locked knees may require distraction under mobilization under distraction to dislodge the loose fragment, and so provide temporary relief, although this is only temporary and may indicate surgery.